afternoon and welcome to NOAHE Rounds, 5th season, 5th session. Please join me in welcoming our presenter, Dr. Andy Chuck. Andy is the Chief Health Economist at AHS, and Dr. Chuck holds a PhD and a Master's of Public Health from the School of Public Health at the University of Alberta. Prior to joining Alberta Health Services, Andy was the Director of Health Economic Evaluation and Analytics at the Institute of Health Economics and co-founder of our network of Alberta health economists that brings these rounds to you. Andy's mission is to broaden evidence-informed decision-making from adoption and into the realm of health system optimization, reflecting the real-world realities of health service delivery, to affect actual change in the improvement of health, value for money, and health system sustainability. Today's topic is value-based decision-making, Panacea or Déjà vu, hardwiring evidence and implementation science into allocative decision-making in AHS. I just want to remind folks of our logistics for the webinar. All of the attendees are on mute. We expect you to use the question and answer function within the meeting software to tee up your questions for the end of the presentation, and all of the questions will be addressed, or as many as possible, during the final 20 minutes, 10 minutes of the webinar. Thank you again for joining us, and now I'll hand it over to Andy.
Awesome. Thanks so much, Kate. Hope everyone can hear me. Let me know if you can't. So first of all, thanks so much for the invitation to give this talk. I don't plan to talk for a long time to save more questions at the end. We'll see how this goes. But before I get started with the actual content, I just want to take a minute to acknowledge and thank all of those that have been part of this journey through a confluence of different pieces that have been occurring at AHS and it all coming together. Some names I just want to highlight: the Nat, Lorraine, Hanji, the heart and soul of the sustainability program at AHS, the technical health economic working group, Ariana, Barb, Tom, all of you guys, thanks so much for all the debates on methods. And then everybody else listed here, you've contributed in a significant way. So thank you to all. So with that being said, let's get started. So yeah, my talk's about value-based healthcare, right? And is this the holy grail for health? And the term value-based healthcare, I think, really started to get steam in this paper that Michael Porter from Harvard had published in the New England. Okay, and it was touted like, let's see if this works, right? This is what he's talking about, right? What it is, it's about focusing on outcomes and relating dollars to outcomes, et cetera, et cetera. And it was the strategy that will fix healthcare. And before COVID, I don't know if any of you would remember, but going to a conference pre-COVID, what I heard routinely at the talks was the word value. Value-based this, value-based that, value, 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 value. And it was talked about everywhere, right? And if you even Googled at the time, any of the conferences, you'd see VBH everywhere. Okay. The thing about it, though, for us that have been part of the evidence producing world over this last period of time is that it didn't seem to be new, right? Here's a paper that was published this 20 years strong is the question, but it's like been 30 years since the paper looking at concepts about evidence-based medicine, HTA, et cetera, right? And how we've looked at this. Like we've looked at value, okay? CADIS, IHE, other think tanks around the globe, INATA, HTAI. There is a proliferation of evidence producers that looks at value for decision-making in health, right? And so it makes the question like, have we not seen this before? And so really is it then therefore the holy grail that it's been touted to be? So let's think about that. Okay, even in Alberta, this is just showing the evolution of HTA in Alberta. And this is something I got from IHE's very own John Sproul. John, if you're on the call, thank you so much, my friend. This is totally plagiarized from content that you've sent me, okay? But this is to give you the idea that like even in our province alone, HTA has had a long tradition. And in fact, if you think about then the birth of code and CADIT, Alberta played a pretty important role in that, okay? But since 93, there's been evolutions of this kind of thinking. And you can see here, again, listing out all the different iterations of that, okay? So what's really different, right? We've done this for a long time. And when you look at the VBH objectives that would be discussed and presented, doesn't it look a lot like Quad Aim? I know you guys can't speak because you're on mute, but when I looked at that, I was like, that looks like a lot like Quad Aim. Again, this is really familiar, right? So is this not the biggest no-brainer in the history of our history? Like, come on, right? So problem solved, right? And I think if someone to ask you, yeah, has knowing now, or if you agree with me that there's been a tradition of this already, we've seen this before. I think many of you though would agree, we haven't quite slayed the beast on health system sustainability. Okay, so if you agree with me, let's keep going. Okay, all right. So what is then therefore missing, in my view, about why maybe we haven't been as effective as we could have been with this tradition, right? So first, of course, right, we need to define costs and outcomes. It's not that I'm disagreeing with the focus on outcomes, 100%. Let's focus on outcomes, and we need to be able to contrast what happens with what we're investing. Sure, got that. For those that know me, I've been a sort of almost a nagger of, we need to make sure that what we produce in terms of analyses as evidence, reports, etc., has to be contextually relevant. Okay, you've all seen this before in terms of the transferability of information conducted elsewhere and the degree to which we can use it in our local setting. There's lots of holes in the assumption that it can. And so I've always said we need to have our own look relevant to our own context on what the evidence would bear on particular policy or decision question, okay? But the most important part, in my view, has been it then all needs to be hardwired. When I mean hardwire, it's not just the evidence, but it's really the whole after the decision's made, then what? In fact, that's probably where the real magic occurs, okay? In terms of implementation, reporting feedback. This is where we walk the walk, okay? It is not enough that we produce the report, okay? It requires, it necessitates more than that, okay? It really needs to be informing the decision at the decision table itself. This is what I'm talking about here, okay? So let's talk about what this hardwiring has been. Well, I guess all of this has been for AHS over this last period of time in this journey we've all been going on, okay? So how do we operationalize? And this is going to be really quick. The first is, can you please define what you mean by value? How many of you in those conferences pre-COVID, when you're hearing this word value, we're thinking to yourselves, yeah, that's fantastic. What do you mean by that word? If you don't define it, that word is empty. I don't know what you mean. I don't know what to do with it, okay? And so the first step is, you gotta define what you mean by that. And it's not meaning we need to reinvent the wheel, but it's really about formalizing what it is you mean. So this is not reinventing the wheel for AHS. This is quad aim, 6 dimensions of quality. We're adding cost effectiveness, equity, and feasibility to it. It's not rocket science, but we want to be explicit about what it is that we mean. Okay, that's the first one. The second one is, you need a framework that's operational. Anything that's high level, not helpful. Okay, give me the principles, not helpful, unless you can operationalize and tell me what that translates in terms of mechanisms and machinery and the engine that's going to make this thing run. It needs to be operational. Okay, and again, the operational, the heart and soul of this at AHS is going to be the sustainability program. In fact, this is their slide. And within the program, it is an integration and joining of forces between clinical operations, service planning, analytics, finance, human resource health. It's really that coming together to make it operational, not just to inform the decision, but as I said, the magic comes after. What are you going to do? How do you follow up? How do you report? How do you hold people accountable? All those kinds of things. Okay. The third, okay, you need a single process that applies to everybody, right? Because if you allow deviation, okay, you're not going to achieve the culture change. Okay, and let's be honest about this. This is, for some folks, this is not fun. This is not fun, having to now demonstrate value and meeting evidentiary requirements and all those sorts of things, okay? But you really need to have the discipline to adhere to it. It takes will, okay? And you need that to, again, drive that culture change. This is the process that that comes out of the sustainability program. And again, it's not too complicated. It's intentionally simple, because it's not meant to be onerous. Okay, but as you identify whatever your initiative or solution has to be, there's a diagnosis stage. Okay, and in that diagnosis stage, you see there's this off-ramp to innovation pipeline, which is another piece of work that happens in AHS, which is really a triaging of ideas. Because you can imagine there's all sorts of awesome ideas in the health system. Some are early days, some are ready for prime time. How do you differentiate what's ready for prime time versus what might need further research, et cetera, right? That's what this off-ramp is. If you are good to go, you go into design, you get your day in front of executive for decision. If they approve it, it's delivered, and you iterate. It's essentially all it is. But a single process, one to rule them all. Okay, that's the third one. The fourth one, okay, your evidentiary hurdles need to align to your value definition, right? This is why it's so important to define value, what you mean by value, because your tools have to align to what it is you mean. If there's a disconnect there, then what are you actually doing, right? It's not, there's no consistency. And this table is just to again, illustrate that depending on the idea, if you're sort of early days proof of concept, you're not required to do full-blown cost utility analyses, et cetera, right? But as you kind of progress and evolve in your readiness for prime time, and the stakes for prime time is important, right? If you're ready for prime time and you get budget, that money, that funding is essentially operational dollars in, I don't want to use the word in perpetuity, because of course there's always opportunity to change and course correct, but nevertheless, like the stakes are high. Like this is real operational dollars, okay? And Kate, I hear you on your mic. Is there a question that I need to answer, or should I keep going?
Nope, keep going. I
Okay,
think Jeff joined us and was briefly off mute, but
okay, cool.
Is great. Keep going.
Okay. And so this is what in AHS we're saying would be in that sort of off-ramp, and we're triaging things like step 4, step 5. This means you are ready for prime time. You can see what that therefore means in terms of the hurdles, or sort of like the burden of proof that you would want to have to come with. Because again, the stakes are, if you get approval, that's real operational budget, essentially in perpetuity, right? So this is why there's this continuum of what would you need depending if you're early days or no, I'm ready for prime time. This is good to go, and everything in between. Okay, but fit the purpose, and your tools align back to your definition of what you mean by value. Okay. The fifth, consistency and incentive compatibility. Okay, so I talked about, yes, it's cost and outcomes. You got to make it contextual, and I talked about the hardwiring, but I need to emphasize, right? Your internal consistency about how your tools and your process, your decision criteria, all of that aligns back to what you meant by value. That has to be consistent, right? That's the first part. But this incentive compatibility part is really, really important. And I am referring to the game theory definition of incentive compatibility, but I would try to sort of like illustrate, or I should say, it's more than really that. And what do I mean by that? There's the art of conveying information that would resonate with decision makers that is relevant to their world. Here's an example. We have never talked to decision makers at HS about Lambda. I've never talked to them about thresholds at all. The second I talk about Lambda, I got to explain what Lambda is. The second I got to explain it, I've lost, okay? The way that we try to articulate the information we're providing is really around, if we're talking about, if it's the context of Lambda, just as an example, okay, it's really about talking about health forgone to other patient populations. That's a more relevant, I think, tangible thing for people to get their heads around, okay? But it's the idea that, yes, you can be internal consistent, but it has to be packaged in a way that they can understand and action that's relevant to their world, okay? Another piece to this about incentive compatibility that's really important. Do you know who holds the purse strings in these kinds of organizations? Of course, the decision is with executive, but it's departments like finance. Do you think finance know what Lambda is? No, they don't. In fact, it's something where, as sort of as an aside, I've been advocating that graduate programs should really have health econ more closely connected with business schools. Because in the real world of organizations, that's run by accountants. You need to be able to work with accountants and all of the kind of processes and rules around accounting so that it is relevant and practical in the real world, okay? In the world of where executive, et cetera, are making decisions. Okay, what's the 6? Complete integration and follow through. And this is where I'm going to emphasize the magic part, right? Like, so yes, there's, again, that triaging, there's that product, right? It goes through the sustainability program. There's advice that would be issued, right? Executive decide. I've said this, but this is the part, right? The sort of the word of magic. It really is this, as I say, that joining of forces that after the decision, well, what then therefore happens? Because you can imagine in the real world, it's not enough to know, oh, something is less than lambda and therefore it's cost effective. That's really not enough, right? We live in health. Greater than 70% is labor. 92% of labor is unionized. You need to be able to work with the realities that, well, that means that's collective bargaining. There's rules around any kind of resource investment, whatever, is going to, then therefore you have to work within the realities of that, right? And so therefore it necessitates, again, this joining of forces between HR, finance, sustainability program, economic ops, CPSM, et cetera, to do all of this. That's what's happening, right? And this is what I mean about, this is really where the operationalization, the magic happens, right? We've done the work to have the evidence to align to the value definitions, and even after it's internally consistent and incentive compatible, this machinery has to work in unison. Okay, then there's reporting, right? And this reporting is also, again, of course, for our learning adaptive health system, right? The reporting back and to see how things are faring. And of course, that reporting is necessary for accountability. And then there's opportunities there for course corrections. And then you just do the whole thing over and over and over again. Okay. This is a guess about maybe, because this is, I think, a health econ audience, and the health economists might be wondering, well, what about ICERs, right? What kinds of economic analysis? So I've alluded to it a little bit in terms of what would be the expectation given if you're early days or versus prime time. Okay, but to kind of talk about ICERs a bit more, okay, I'm gonna kind of situate this in the context of AHS's journey on high-performing health systems, okay? So at a high level, what are the characteristics of high-performing health systems? It's like they have established care pathways. That's not too prescriptive, right? They account for all of the inputs and resources needed to deliver that service. They know what it costs. They know what happens. And then they have a CIS, a clinical information system that leverages all that information, and it permeates across the whole organization from frontline all the way to C-suite, right? And for us, right, we have this feedback loop, the same, the program is really, really important, et cetera, okay? So we have all of these ingredients that we're sort of, that's happening on, again, the road to achieving these characteristics. And so, as I said, they know what to do, they know what it takes, they know what it costs, they know what happens, it permeates, they learn and adapt. Now, we're not doing yet full-blown CUA, okay? And it's really because, well, what's our measure of HRQ or health outcome, right? And the HRQL instrument that we're advocating is EQ5D5L, okay? And Connect Care is going to be a significant enabler for us of that. You can imagine, I can imagine, I'm envisioning it now, and I'm getting so happy that one day there ought to be a time where we have EQ5D5L in Connect Care and will be better able to measure health outcome directly, right? And at that time, we would then have the opportunity to do really full-blown CUA, and imagine that like within AHS across so many different kind of areas. But in the meantime, what are we doing, right? We're doing the best we can, right? In terms of sort of more CBA, sort of ROI, those kinds of analyses, CUA if it's available, but more CBA and ROI as it informs this decision. But again, the end state, or sorry, not the end state, but one of the goals moving forward in the future through Connect Care will be CUA. Okay, if you guys are all wondering, I think maybe that was my guess on my part of health economists are wondering, well, what is it that we're actually doing? Okay. So in a nutshell, we have implemented in our following AHS VBH, okay, right? This really is the first operationalization at a provincial scale and in the largest health authority. So again, this is really, really cool. Again, credit goes to not me at all, but all of those that have been part of this journey. I'm doing all the talking, but I definitely did not do all the work for sure. I think it's pretty cool if someone said to me back in my, early graduate days, hey, Andy, one day you'll be able to kind of work on this kind of work with the people you work with in like the largest health authority. I'd be like, yeah, right. But no, it's really been, I've just been so privileged. But with that being said, let's talk about this a bit more, right? So we're very proud about AHS on its road to value-based healthcare and value-based decision-making. Is it perfect? No. Will we get better? Yes. Are we gonna strive to continue to improve? Absolutely. But the premise behind my talk was, well, is VBH the panacea, right? Or is it just deja vu? And I think I've answered the deja vu part. But let's answer the, is it the panacea part? Is it really the strategy that will fix healthcare? And my view is, we need to really kind of be honest with ourselves, right? So this is a diagram showing what part of health outcomes is actually influenced by medical intervention, right? And it's about 20%. And I don't even care whether this number is right, whether it's 30, 20, 15, we know that it's not everything, okay? And that the biggest factors are social determinants, right? When I was young, did I have a roof over my head? Did I have food on the table? Did I get to go to school? Did I then pick up bad behavior habits? All those kinds of things are bigger predictors of health outcomes. And by the time unfortunate event happens in health, it's kind of too late, right? So again, the 20%. So if that's true, okay, if that's true, well, then the implications are as follows, right? So again, here's the VBHC, what it wants to achieve, and what the way it's been kind of thought about, it's really in that, it stays in this box. And if that's the case, well, that means then, even if the health system was perfectly optimized, we did everything perfect. At best, we are impacting 20%, right? So how can something be the panacea if you can only at best impact 20%? And so I think that's the issue with that, right? Not to say that value-based healthcare is not important. We should optimize 1000% this box. We should continue to do that. But to somehow tout it as, this is everything, folks, we don't need to work anymore, pat ourselves on the back, we can go home. That's not true. There's so much more work for us to do, okay? And really the inconvenient truth in achieving that nirvana, okay, is that the solution resides outside of that box, which makes it so elusive, because most of the time you think we gotta look within. We need to figure out what our issues are. We need to address and make sure our house is in order. But in this particular case, it actually requires a looking out and a connecting out, opposed to solely looking in. If you continue to solely looking in, the best we're gonna do is at the 20%, right? And then therefore no report, no innovation, no nothing, no healthcare reform is going to fix that. Because again, at optimality, you've only improved the 20%, right? And so I'm asking you guys this question, is particularly for you young, early career folks. As a community, do we need to begin unobsessing? And I'm not saying, again, that box A is unimportant. absolutely, let's optimize A. But I think we kind of got to admit, we spend a lot of energy in A. ICERs, discount rates, sensitivity analyses, other guidelines, et cetera, et cetera, et cetera. We spend a lot of energy here, right? And when I say about community, I merely mean us being broad, granting agencies, what you're funding in terms of research. Maybe we start thinking about the connection and integration with these other parts. Because if we're being honest with ourselves and we want to get to nirvana, it's going to necessitate that. It's just the facts, okay? And if we've shifted, or maybe, again, it's more of a rebalancing, because we can't ignore A either. Let's optimize A. But this rebalancing and this refocus, I think we will do more to move the needle than we possibly ever will do if you only solely continue to just look at what's in box A, right? And I know this is not for the faint of heart, because you're saying, well, heck, we're working so hard to optimize A. And now you're saying we gotta optimize A as well as all these other things? I guess, yeah, that is what I'm saying. And I know you may think I'm crazy, but it is the facts, and it is not for the faint of heart. But the late and significantly great Cy Frank, I will never forget this lesson he taught, which is basically that impossible just takes a little longer. And in fact, in AHS, the way we're thinking about VBHC and looking at social determinants is continuing to evolve through Richard's work at AHS. I would say to you as health economists, if not us, who? We're almost the best situated to do this. If anyone deals with messy data and creating and identifying signal amongst chaotic noise, it's this discipline. That's it. Thanks, everybody. Hopefully that made sense. Happy to answer questions.
We have several questions queued up. We'll just go through these in the order that they came in. First, someone asked, would you be willing to speak a little bit more specifically about the sustainability program? What's taken into account when considering sustainability?
Yeah, so it relates back to, so how do I say this? The sustainability program is a formalization of how we manage investments in the organization. Okay, it's really becoming professional about how we do this. This is not off the side of the desk. It's not, sort of ad hoc kind of processes that, I have a pressure, I have a new idea, can I go get money for it? Thank you very much. It really is becoming professional about the whole coordinating, challenging, tracking, reporting, course correcting of investments. That, I think, at least that's the vision. Again, are we perfect? No. Are we going to improve? Absolutely. Okay. And so what we're taking into consideration as part of the information that's part of the, that informs this process of track and challenge and eventually decisions is back to the value definition that I presented earlier, right? It aligns back to its quad aim, 6 dimensions of quality and all that kind of stuff, addition to feasibility. And so I hope that answers your question. But I do believe Natalie McMurtry is on this call, and maybe NOAA should invite her as a follow-up to present on SPO specifically. I think that would be really, really cool.
Yeah, that would be great.
Sorry, Nat, if you're like, oh, why did you volunteer me for that? You can get mad at me after.
Well, we'll offer an out if it doesn't work with the schedule or something. But yeah, it sounds like a great idea. Next
question.
Yes, next question. You mentioned connecting more closely with the business school. What do you think needs to be taught?
Okay, it's kind of like both ways, right? So, so when I joined AHS, I was sort of like this parachuted health economist in, and I've learned a ton, okay, about how things really go down. And I think it would be really, really enlightening for those of us that were trained in schools of public health, departments of medicine, evidence-based, world, to know what it's like and what the realities of budgeting forecasting reporting is, because you have to kind of understand the dance with government, the dance that occurs internally, and how the machinery works. I think that would really be enlightening. And then what we can bring to them, because it should be mutually beneficial, is concepts of opportunity costs. It's different kinds of analytics. It's different kinds of, well, yeah, for instance, right? The reporting in finance is mostly on financial reporting and activity. Well, dollars and activity isn't necessarily value unless you have outcomes and how, et cetera, right? And so that broadening of thinking of, again, what you define as value is important to marry that into finance and all that kind of stuff, to then have broader perspectives of what's actually a good buy or investment for the health system. So it's definitely mutually beneficial, but those would be the kinds of things I think that would be really useful for both worlds to get appreciation for.
Excellent. So next question. How does AHS decide what to stop funding, i.e. de-implementation, to create budget room to implement new interventions?
Yeah, that's a great question. So there is processes. So even like, look, AHS review is a huge example of that, right? This is nothing that's secret. It's in the public domain. People know that AHS had a review, and of that, there's several initiatives with which have been approved for us to go ahead. So that's a start. And again, the sustainability program was born from that review so us to become professional about how we manage those kinds of initiatives, as I said, in terms of management and investments, but as well as disinvestments and opportunities for improving efficiency within and across the organization. So, but in addition to that, right, there's a process and discussions, particularly during budget planning time, where the organization does examine other areas and opportunities for quality or efficiency improvements. And it goes through, again, the same kind of sort of machinery of being brought forward. Clinical appropriateness is probably a great example of that, right? I got this awesome idea. It's going to save money and improve outcomes. You need to invest 2 million and I'll save you 10. Right? Is those kinds of things that then come through the sustainability program for track and challenge to see, oh, you really, if I give you 2, you're really going to save 10, that kind of thing. And it goes through the whole cycle and that whole process that then informs budget planning and the conversations every year that we go through in terms of planning with government. Hope that answered that question.
Yes. And next we have, I'm interested in how AHS compares evidence with different outcomes, in particular when cost utility analysis isn't possible. In addition, how do you avoid conversations on the value of lambda? Do you use ICERs comparatively or net benefits?
Okay. It's a great question for sure, right? And as I said, like until Connect Care is fully operational and we have EQ5D, 5L everywhere, we're not going to be able to do CUA in the way that we would love to do, where you have across 20, 30, 40, 100, I don't know, whatever, pick your number, different initiatives. How are you going to make the best sort of choice across them? Okay, we're not quite there yet. There's pockets of CUA that occurs where it's available. A lot of, so if those that are familiar with Prius competitions, you might see it there, but for the most part, it is more CBA, more ROI, but to your question, well, how do you get the apples to apples? It's really, really tough. It's sometimes things are framed more in terms of risk, right? Or we employ criteria, rules to help prioritize. So, again, amongst the 20, it's not sort of CUA across them, but using criteria and logic, there is a hierarchy where you can sort their priority. And so we kind of can go through things that way. But honestly, until Connect Care gets us EQ5D across the whole system, CUA is not going to be readily available and doable, because again, the health outcome side is just this, unless you have it, you can't do it, right? Okay. Is all this complexity helpful? People need to change for innovation to deliver its benefit. Are we making it too complex for these people? Of course, I'm the converted. So what I presented to you, I didn't think was too Oh, that just changed.
Oh, I think Nicole is as the questions are addressed, she's editing them out, or they're editing out of the queue. So that's why it went away. And I was prioritizing the ones that weren't anonymous, and if we got through those to jump to the anonymous ones, but you took the lead on that.
Okay, yeah, sorry about that, Kate.
Oh no, it's okay. If you want to see that question again, you can click on the answered tab.
Yeah. So to me, I of course, as I say, yeah, Andy, because it's coming from you. Of course, you don't think it's complex. I honestly don't think it's that complex. It's like, and I also think it's completely legitimate that if you're coming with your handout saying, give me $50 million of primetime dollars, that it's totally fair for us to ask, what are you going to achieve? How are you going to achieve it? And you need to report on it. That's essentially all it really is, right? And I think that's pretty fair. So maybe I'll leave it at that.
Excellent. And then Braden Mans says, wonderful presentation, Andy. Agree as you say that once a program gets operationalized, funded, it's hard to remove funding. There's a few programs that have been funded through the sustainability program. Can you discuss the interim reports? Are they creating value we hoped for? Have we pulled back on funding of any of these? And is there a plan to put the value lens on some existing programs we're funding, potentially removing existing activities to create that bandwidth? So related to the prior question, potentially about defunding.
Yeah, I would say for the most part, things that have been approved through executive, like once that happens, it is basically green lights, release the hounds, kind of so to speak. If there are course corrections that are made, there are processes, change order forms and all that kind of stuff that have to come back to executive for their approval for that to happen. So as far as I'm aware, I don't know whether there's any specific initiatives for which suddenly, we're pulling the plug. If they're green lighted to go. If there's course corrections, they've made it, but I don't think there's been sort of any kind of like stop the train kind of situations. And is there a plan to put a value lens on some existing programs we are funding? Yeah, absolutely. Okay. So again, are we perfect? No. Are we going to get better? Yes. And as part of getting better is being able to look at the value of existing programs. Absolutely. That will be significantly enabled once Connect Care is up and running, of course, right? To then look at areas which we can kind of determine, like, are we getting the best are patients getting the best outcomes for the dollars being invested comparatively to elsewhere? Yeah, that is part of the plan. I think, as you know, we kind of do that now in sort of spots, but to do it in a systematic kind of way across the org, it's going to be significantly enabled through Connect Care.
Great. And now the next couple questions are kind of relating to the end of your presentation, particularly the social determinants of health. The first one, do you think cost utility analysis has a place in informing improvements in social determinants of health?
Like yes, in a way. So again, this is my simple brain. Okay, simple brain. It's not that the VBHC or even CUA is as I said, like if it focuses just on A, we're only going to get to at best 20%. But imagine any kind of intervention or policy or idea or innovation. All I'm saying is that it has to make the connection if we really want to get more than 20% across those social determinants. And is there a more concerted, programmatic program that crosses the social determinants that then have impacts on health? At the end of the day, it is still health. That is the maximand. I'm not saying that suddenly that changes, right? It should still be a final outcome, and health is, what better than that? And it would still, I could see it, the denominator has not changed, and so COA has not changed. It's really just broadening the intervention. so that the intervention itself is more encompassing than just trying to fix what's in box A. Right? Even as something as simple as better connectedness through environment and in the way city planning is done, right? If there's better ways to look at that and its impact on health, then to me, it still seems like COA is usable because the denominator is still health.
Cool. And then the next one is, should a value-based healthcare system be evaluating policies and interventions focused on the social determinants of health and then advocating for investments outside of the health system's budget?
Yeah, I don't know whether it's 2025, right? Like, as I said in the talk, I really don't, like, to me, the number doesn't matter. It really is the reality, though, that by the time I have a heart attack, it's kind of too late, right? That's really the issue, isn't it, right? And so there's only so much health intervention what's happening in that box A is going to do, right? It has to be way more upstream. So I guess that's really my point. I don't care whether it's 20, I don't care if it's 40. It's just that reality that health can only do so much. By the time you have a stroke, sorry, it's kind of too late, right? We're going to intervene. We're going to, give you your care, but right. Sorry, I missed the beginning part. There's a second part to Brent's question that I kind of missed.
Oh, I think it was Darren's question.
It was Darren's question, sorry.
Yeah, and it already moved. So the thing was, the second part was, should you be advocating for investments outside the health system budget?
Well, yeah, okay. So that's the thing. I don't know what, like, in terms of the strategy, what to do in terms of advocating for what money comes where. The reality, though, is that there's lots of money out there. I think OECD last said that Canada spends 21% on health. So that means there's 79 elsewhere, of which I would suspect a whole big chunk of that is in those other determinants. It's really about siloed mentality, I think, that I am raising as the issue. That interventions and solutions do not be constructed in isolation. Because when they're constructed in isolation, that then doesn't really optimize what you could do. I guess is really what I'm trying to get at. And when you look at things in isolation, there's not the opportunity for rebalancing the portfolio, because perhaps housing should get more money than something else because it gives you the biggest bang. So it's really that siloed isolation planning mentality that I'm identifying. And so if you do whatever you want in health and, oh, by the way, can I get 10 more million to do this? I think that's still going to lead to the same kind of disconnect that we've seen. Because it's not a money problem. There's lots of money. It's really about a focus, a integration, a connectedness problem.
Great. And so next, our very own John Sproul asking, who you mentioned earlier, does this support review of existing embedded resources that might be extracted to invest in new priorities, or just new dollars, lots of sunk dollars?
John, buddy, can you kind of elaborate on your question? Not quite getting exactly what you're asking.
We'll give John a shot to iterate on that.
Okay.
If you've not quite got it from there. And do you think some of the earlier conversation about defunding is related? And yep, John says it's already been answered.
Oh,
so,
okay.
Great. So next, you mentioned value-based health only influencing the 20 to 25%, but is this true? Would not a truly integrated system around value-based health not include social determinants? And I do think that's what you were just getting to in your prior answer, thinking about that of, breaking down silos a little bit.
Yeah, it's really the expansion of our scope, right? When you look at VBHC, it says it really has been more on within health. If you focus on outcomes, it's gonna save everything. And all I'm saying is that if it's narrowly and you only look at stuff in that box A, I think that's a problem. right? It's expanding and looking at it more holistically and making those and planning with intent to incorporate those elements of social determinants. Intent.
Cool. So I see a question. How does A measure compared to overall
21% in Canada.
Okay.
And health expenditure. In terms of overall government expenditure, I think is about 21% in Canada. I don't know, Nat, whether that was the denominator you were looking at.
And then next question. Can you speak more to what you said about cost utility analysis being in the future with the addition of EQ5D for Connect Care? Two questions.
Yeah,
what about conditions for which EQ5D isn't appropriate, i.e. not validated?
Yeah.
And you mentioned AHS does CBA now. Do they do full CBA? How would that happen without
it is not full CBA. Yeah. Okay. So hey, Jillian, long time no chat. Nice to see your questions. Yeah. So COA is something that we want to aspire to for sure with Connect Care. So I think that part is not really your question. The two questions that is about, so things for which EQ5D, absolutely, that's an area where it's going to be a gap. But as I say, are we going to be perfect now? No. Are we going to get better? Yes. Are we going to continue to evolve? Absolutely, right? So this is all part of the thinking. And in fact, the question to your answer to your first question is we're going to look and need help from the community as well about how we do this, because this is not just an AHS problem. This is an actual evaluation problem, as you know, about the fact where EQ5D is the best tool. And so we're going to look to what the community has to say about that, right? This is not AHS doing everything by ourselves, for sure, absolutely not. To your second question, is it full CBA? No, it's not full CBA, right? We have not monetized the health using Lambda or anything like that at all. In some cases, I should say, we do bring elements of that, but in the way that you're asking, the short answer is no. Again, we try to give the best context to the economic analyses, supplemented with logic and risk for decision makers to have to weigh through. Okay, but is not full-fledged CBA and is most times also not going to be CUA because we don't have EQ5D for everything.
Cool. Okay, next, I'm going to jump down the list of questions a little bit to touch on one that having to do with that discussion of silos and scope. To what extent is Alberta Treasury Board aware of your work, and are they interested in using it to advance government-wide expenditures?
No comment. No comment. I'm not.
I thought you'd like that one.
Yeah. I would like, but this is not just for Alberta, right? But this is sort of. So as a private citizen, as a Canadian, I would hope that the idea of this begins to take root and starts to propagate. Because again, I don't care whether it's 20 or 30 or whatever, right? The way that we're approaching how to get to sustainability it has to look at the broader social determinants. And would the nirvana be cross-ministerial policy development, right? Yeah, that's kind of what this is kind of saying. But the degree to which our governments are thinking about this, I can't comment for sure. Do I hope they begin to? Yes. Do I think we can help them think about that as a community? Yes. This is why in my talk at the end, I said, if not us, who? We are masters at dealing with noise and crazy data, guys. We can do this. And I think slowly through this, if we can focus our energy to be more balanced, to include social determinants, I do believe we'll move the needle toward that becoming a must, or people being aware that it's a must, I should say. That's my plea to you all. But anyways.
Awesome. So John with another question. Would this process benefit from having different funding models? Activity-based funding or bundled payments, for example?
Yeah, okay. So the short answer is yes, but I have a different angle to that in addition, John. Okay, so even in box A, what's been the challenge? Okay, this is almost another lecture. The challenge isn't so much, do we got the right evidence hurdles? Do we have the right burden of proof criteria? It's not so much, oh, we're not good at innovating. It's not any of that. If you look at the data, holy smokes, we adopt a lot of stuff. What I see as funding models and those kinds of things helping is in accountability. Accountability and integration, not within just AHS, but also into primary care. And that kind of stuff. It's really about accountability, that if we're just looking at box A, what would really help box A is accountability. Okay. That and funding models, as you know, would help that, because if you create models that incent, right, doing the right thing, or et cetera, right, we've talked about this before, that would really, really help box A. It's not, is my discount rate correct? Is it not, oh, can I do this sensitivity analysis in like to the nth degree? Guys, we could work on policy on accountability. That in box A would move the needle more than any of those technical things.
Great. Next, in terms of small companies kind of with innovative ideas who may be working to show value in terms of cost effectiveness, what else should they be thinking about to make those analyses more attractive to AHS in the sustainability framework?
Well, great question. First answer is, you know, the value definitions of how we kind of lay that out. It'd be really good for innovators out there to understand that, because that sets up the rules of the game, right? Understanding the rules of the game, I think, would be beneficial, right? The other thing I'd like to actually say, since you asked the question, is I also want to use this opportunity to also bust another myth. And the myth is that AHS does not support homegrown innovation. So if you think that the budget is around 16 billion, 13 billion is of the 16 is invested in Alberta. Of course, that includes labor. But when you're looking at sort of like suppliers and other companies, it's like another 4 billion that we invest in the province just for that. So I just want to put out there, we are investing in homegrown already. So I want to, if there is those that think that that's not happening, no, it is actually happening. I've seen the data. It's true. But then the second part, familiarize yourself with the way we've talked about value and those kinds of pieces. And then in terms of people to connect with, you know, Mark Leduc's team, I don't know whether Mark's on the call, right, in terms of connecting with companies and stuff. But what I see is the benefit is like, at least you know what the value definition is. And then from there, it should give you an idea of what you need to be kind of coming forward with in terms of merits of your innovation.
That is great. And apparently there was a question from Amity that I can't see. Jeff, would you be willing to read that question? I'm not sure where it got to.
Yeah, sure. I tried to send Amity some information outside the actual question, and then it got skipped over to the answer. But Amity wanted to ask, how could we include paying for equity in the value definition?
It's a fantastic question. So the thing about equity, so I'll tell you my own experience with it. So sorry, back when I was in the day of doing HTA, right? Do you remember what those ethical analyses were, or this equity? It was kind of be more of a narrative descriptive kind of, well, what are the ethical principles and that kind of thing. What I felt was lacking at the time was it needed to be evaluative, right? You got 2 interventions, 3 interventions, or whatever it happens to be. It needs to be comparative and evaluative to say that from an equity lens, this one improves it more by what, okay? I was pleased to see from the work, I think Duncan, I don't know whether Duncan's on a call, but Duncan is the sort of resident ethicist, clinical ethicist that we have at AHS who's been part of some of this work, right? That they've come up with a way and an approach of moving the needle in ethical analysis to look at equity from a comparative evaluation point of view, right? And so as part of that now then feeding into our value definition, where equity analysis is conducted, right, you would be able to see A through Z what the sort of equity kind of incremental benefit would be, that kind of thing. And that's the vision of how I think it would be incorporated as it then therefore informs adoption decisions or other decisions by executive.
And for those who are interested, you might want to check out Richard Cooksin's textbook from last year. I think it was, or possibly late 2020, on distributional cost effectiveness, where several different people with him go through different ways to put equity into an evaluative framework as well, and incorporate it into cost effectiveness considerations. Okay, back to you.
Okay, great. Kind of the last, I would say, thematic area covered in a few of the questions relates to what the usefulness is directly to Albertans of the processes and the information generated, and would that end up getting to a state where individual Albertans might use it to inform how they proceed in making choices about their care and what locations they would go to receive care? Or is it not going? It's hard for me to think about, because I'm thinking about this more as from a system decision making. But do you think there's any role in the future for individual decision making?
Honestly, I don't know. We were approaching this from the same perspective as you, Kate, from system decision-making lens, right? And of course, being good stewards of resources, I'd hope if Albertans were to be aware of this, they would be like, oh, I'm glad that my taxpayers' dollars are being utilized towards the highest value stuff. I think that would be great if they came away with that. The degree to which it would actually influence their own personal sort of empowerment of controlling their and managing their own health, I don't know. I don't know.
And I think that's fair. And I think, like, with that, we've really covered most of the ground that came up in the questions, and that excellent to have so much time to field questions, and really appreciate you giving this presentation and answering so many questions today. And virtual applause for you. And folks can sign up for our next round session on the NOAA website. And thank you all for attending.
And Kate, can I say one thing before
we absolutely.
So just want to say, Kate and Jeff and the IHE team, thank you so much for the invitation, and thank you so much for continuing to grow NOAA. Back in the day when NOAA was in its just a little baby in people's brains, you know, we could have only hoped that it would continue to grow like this. So kudos to you, Kate and Jeff, for continuing to grow NOAA into what it is now. I'm sure that it's going to have great, it's going to achieve even much more in the future, but just want to say thank you for that. And thank you so much, everybody, for all your questions. I hope it made sense. And thanks very much for the invitation.